Welcome to this third edition of the Points of Care, the official podcast of the Journal of Diabetes, Obesity, and Cardiometabolic Care. This is the American Diabetes Association's new journal for clinicians, educators, and advanced practice professionals. I'm Dr. Richard Beaser, your podcast co host. And joining us, of course, is my co host, Dr. Jane Reusch. Jane?
Happy to be here, Rich.
Thank you. Thank you. Well, this next edition of the journal has a lot of information for people with many, many interests, but I wanted to highlight two specific articles in particular that address cost issues in treating obesity. One article is The Cost of Inaction in Treating Obesity in the United States by Sapra et al. And the second is The Benefits and Costs of Treating Obesity Among Adults in Commercial Insurance Plans by Dahl et al. Now, these topics will be subject of the special journal symposium from Diabetes, Obesity, and Cardiometabolic Care at this year's American Diabetes Association Scientific Sessions in good old New Orleans. The symposium is entitled The Cost of Obesity and Its Treatment. Following that symposium, I'll be recording a special episode of this podcast by the same name, The Cost of Obesity and Its Treatment, with the symposium presenters that'll cover the implications of these important issues. And the podcast will be available via the Points of Care feed. So be looking for that. It should be a very interesting conversation. Now, I also want to mention another special podcast episode, which is becoming, as I'm told, an annual tradition, although Jane and I will be joining it for the first time this year. That podcast will feature a live discussion among the hosts of all of the ADA's podcasts to review some of the highlights of the 2026 ADA Scientific Sessions. This episode will be moderated by Neil Skolnick, the host of Diabetes Core Update and Diabetes Day by Day. And in addition to myself and Jane, we'll feature the hosts of our sister journal podcasts, Darlene Sandoval, Kirk Habiger, and Kevin Williams, the hosts of Diabetes Bio, and Alice Cheng and Mike Rickles, the host of Diabetes Care on Air. But now let's get on to today's journal podcast. Jane, you and I will start off with interviews of authors from two key articles. Tell us a little bit about what we're going to hear in those, Jane.
Yeah, today we're going to have the pleasure to hear a little bit about how patient portal imaging gives us some insights into the challenges both on the provider and the patient side for diabetes management for older adults living with diabetes. And second is an intriguing paper about a diabetes camp that has been executed in the Steno group to teach elite athletes and other athletes living with type 1 diabetes to more accurately and safely manage their diabetes.
Two very, very important and practical topics I think our listeners will be interested in. Now, following these interviews, we're going to highlight some other articles that should also be of interesting reading. But again, we're highlighting them, so read them online or actually hold the paper in your hands. I don't know if anyone does that anymore, because these podcasts are not a substitute for your reading the articles. And our goal is really to whet your appetite and have you go and get your own copy of Diabetes, Obesity, and Cardiometabolic Care. So let's get started. It's with great pleasure that I introduce two of the authors of our first article. The first is Dr. Anna Kahkoska, University of North Carolina at Chapel Hill, Department of Nutrition, Division of Endocrinology and Metabolism, and Dr. Joshua Niznik, University of North Carolina at Chapel Hill, Center for Aging and Health, Division of Geriatric Medicine. Welcome. The title of their article is Quantitative Analysis of Patient Portal Messages from Older Adults with Type 2 Diabetes. And this is a very interesting and timely topic. Technology is certainly expanding exponentially, including the availability and use of patient portals, and people are getting older. And a key population utilizing them are those older adults. So, Josh, perhaps you could start by telling us the specific objectives of this analysis of portal usage by this population.
Yeah, thanks so much. We were interested in, as you mentioned, understanding how the recent uptick and adoption of patient portals has affected healthcare communication and healthcare delivery. We know that more and more people are using this technology, but what we don't know is the substantive content of the messages that go back and forth between providers and patients in the time in between their visits that otherwise goes undocumented, unbilled for, and there's information in there that can be useful for us, both in clinical practice and in research. So we wanted to understand the content of patient portal messages, and we chose to focus on older patients with diabetes because we thought this was an exemplar population of folks who would be high users of this asynchronous exchange between visits. We hypothesized that the complex care management needs would lead to greater likelihood of messaging between patients and their providers to talk about test results, glucose monitoring, medication adjustments, and medication questions. So this population was really well suited to address this research question. So what we wanted to know was what are the concerns, needs, and priorities of older adults with type 2 diabetes that they express through the patient portal as reflected in the themes of patient initiated messages.
So, Anna, can you please tell us a little bit about the design methods and the key results from this study?
Absolutely. We analyzed patient portal messages from UNC Health's patient portal, MyChart, and the linked clinical and administrative data extracted from the UNC healthcare system. So we included all patient initiated messages from calendar year 2023 that were sent by adults 65 years or older with established type 2 diabetes who were also receiving endocrinology care at the main outpatient medical center. For our analysis, we conducted a hybrid deductive and inductive thematic analysis, which means that we started with a structured coding framework from our domain knowledge and the literature, but we allowed for the code book to evolve based on what was in the data. And in the manuscript, we report a final set of themes and subthemes.
Very interesting. This is certainly a new mode of delivering healthcare that I think does require some attention. And from this analysis, Anna, what conclusions did you draw in terms of how this population is using the portals?
Absolutely. The results were really interesting, and our analysis has a few key takeaways. The first is that at a higher level, the messaging content actually called for limited medical decision making, and instead, many messages expressed a lot of administrative confusion and requests related to the administrative components of managing diabetes. The second takeaway relates to the barriers that older adults face in terms of accessing supplies. So, we expected to hear challenges related to accessing advanced diabetes technologies, but we were surprised by how many messages discussed barriers to accessing basic diabetes supplies like lancets and test strips. The third takeaway is that there was significant anxiety surrounding lab results and their interpretation, particularly for labs that were released electronically and automatically. And lastly, there were many messages that contained multiple updates or questions of varying complexity and urgency. And we thought about these as compound messages that were asking for routine refills or sharing major medical updates at the same time. And we encourage listeners to read the paper because we actually include examples of these kinds of messages.
You know, it's so interesting to think about how this may be helping us understand and anticipate barriers that, some of these messages look like problems that could be solved just with process of care. And what are your thoughts about that?
I think it would be interesting to understand, looking at the responses to messages, what proportion are addressed by providers versus other staff at the clinic to try to understand what proportion of that like administrative burden is being picked up by providers versus how much of it could be perhaps triage to like a care coordinator who can perhaps better help to navigate some of those challenges.
Or perhaps even proactively, if you see a lot of issues coming up commonly, proactively address them before people even have to ask the question.
Definitely.
Yeah, yeah. Um, I found in my practice that the use of the portal and electronic communication just absolutely exploded with the COVID pandemic and people being more stuck at home. And one of the challenges I found was in older people, we want them to try to get some of their meter uploads and CGM uploads and so on, and that was extremely difficult. What have you found in your research around those issues? Because that could really help with virtual care.
Anna, do you want to take that one? We did look at like technology and that kind of stuff as like a
We
theme.
did. We had a specific code for the messages in which people were transmitting glucose values. And I think that an important future study would be to follow up and see what the messages look like that are responding to those, people conveying that kind of information. Because in our study, we're limited in that we can only see the patient initiated messages, and that was a fair component of messages.
What sort of future investigations are you thinking about, and how might this actually, in your mind, leverage into practical applications in the clinical setting?
One of the things that we're hoping to do is to do a quantitative analysis looking at the frequency of exchanges over time, so over a 1 year period, to identify who are the most frequent users of the portal, and then also to look at the number of exchanges within a single message thread to try to kind of capture complexity as a proxy, to understand the depth to which like these issues are communicated over the portal versus what could be done in a visit. So um, I think that's one important thing, is to understand, who are the patients that are sending messages most often? What do they look like? Are there differences in their clinical complexity, or are there differences according to, things like region and race and ethnicity? Are there potential barriers to accessing the portal? This sample only includes about half of the total capture of our patient population, because the other half did not send any messages during this 1 year period. So I think that's also interesting to understand who is that group of people that's not sending any messages at all, and do they have the same challenges but maybe a different way to address them, or do they not have the same challenges at all? So I think that's useful to know too.
Ver- Very interesting, because this is a whole new paradigm of delivering care that I think we're all getting used to. In final comment, any practical advice to listeners who are in practice and into how they can tomorrow morning be more effective in using their portals?
It's a good question. I know there's a lot of emphasis on this, as the time demands for providers continue to climb and climb and climb. I know that I think this is a good way to put that into perspective, to understand, because otherwise it's not documented anywhere, right? At our institution, each group is able to see the number of messages they send, who are their biggest scorers in terms of who's sending the most messages per month, and what's their response time in terms of the number of days. But it's great that this is another tool for access, but I think it has to not become a barrier, or another contributor to provider burnout. So I think within practices, being able to leverage the teams that you have that can access these data and provide it to you, so you can better understand this kind of black box part of patient care right now. Because I think, again, it's, we're not really looking at this that much.
So I think I can conclude by saying to be continued.
Yes.
Yes, and encouraging people to go and read this really interesting article, which will be specifically relevant to their daily life. Well, it is with great pleasure that I introduce one of the authors of our second article, Professor Esben Vestergaard from Aarhus University Hospital Steno Diabetes Center, the Department of Pediatrics and the Department of Clinical Medicine. The title of his article is The Clinic for Athletes with Type 1 Diabetes, Evaluation of a Structured Clinical Care Model for Physically Active Individuals. Can you tell us a little bit about what your objectives were and the gaps that you were hoping to fill with this research?
Yes, thank you very much. I will do that. Now, we need to imagine how it is being an athlete with type 1 diabetes. Every training session and every competition requires you to balance insulin, plasma glucose, and your glycemic control with nutrition both before, during, and after the physical activity. It is complex and it is difficult, and it's something that standard diabetes care does not address sufficiently. And yet, despite we know that this is difficult, and evidence suggests that education and clinical support tailored to athletes with type 1 diabetes is largely missing from the routine care, we address it here. What makes this even more striking is that it's not just a problem for athletes, it's also a problem for other people with type 1 diabetes. And we have found out that only approximately half of the people with type 1 diabetes have ever received counseling on how to exercise with diabetes. So this is a knowledge gap that we have identified. And this is why we have invented our clinic called CATOD, or Clinic for Athletes with Type 1 Diabetes, here in Aarhus in Denmark.
Thank you.
Thank you. Perhaps we could ask you next to jump in and summarize how you actually conducted your evaluation and just summarize some of the key results that you're reporting, the bulk of which will be in the article.
Yes, we conducted a prospective observational study here at our clinic. This is the only specialized clinic for type 1 diabetes in Denmark for athletes. And it has been working between 2019 and 25. And we've had 180 athletes with diabetes in our program. We have data from 114 of the athletes, and they range from amateurs to world-class athletes. And what we have seen is that when they participate in a 1 or 2 day diabetes camp, they increase their diabetes-related knowledge about exercise, nutrition, insulin dosing, etc., with about 19%. And the most important thing is probably that those with the lowest baseline knowledge are the ones who gain the most knowledge from the camp. We also a significant improvement in diabetes management confidence when we follow them for another 6 months. They also reduce their diabetes distress and also improve their HbA1c. So, in short, the structured and interdisciplinary care model, like the one that we have invented here and use here, result in a real clinical difference for athletes with type 1 diabetes.
This is such an exciting bit of work, and we are going to have this brief sort of discussion to entice our readers to go and read the details, more of the details about this program. But one of the things that I would like to reflect on is the fact that there has always been tension between diabetes and exercise in type 1 diabetes for fear of hypoglycemia and all of that. And exercise is one of the things that will allow people to live a long and highly functional life. It is the #1 predictor of longevity. So in light of that, this is a very exciting project. And can you tell us a little bit about the resources that need to go into this program?
Yes, definitely. The resources would include setting up a team, people with different competences. We would need people with a high knowledge on diabetes, on diet, and on exercise physiology, and about living a daily life with diabetes. So we have endocrinologists, one pediatric endocrinologist, a dietitian, a sports physiologist, a nurse in our team to take care of the program, or to take care of the people in our program.
Great. So Esben, I would love to learn a little bit more about what you thought was the most important and critical component of the program.
Yes, what we experience as professionals when we gather people with type 1 diabetes at the diabetes camp is that it is a one-time experience for them to see so many people with type 1 diabetes focusing on exercising safely without developing hypoglycemia, and also where they can learn from each other and where they can make new friends and interact and learn from professionals that are totally dedicated to teach them about how to control their blood glucose before, during, and after exercise. And this is really what I see as the most important thing about the camp.
Yes, so I think that sounds like what the magic is this sort of professionally supported peer engagement to really get to their best exercise capacity and their best exercise safely and confidently. So I just want to encourage our readers to take a look at this wonderful article that was pulled together with the intention of improving the lives of people with type 1 diabetes. And I want to thank our author today and entice everybody to look for more news on this topic.
Thank you so much.
We're going to start with some of the other articles that Jane and I are going to just highlight. First one is entitled Rural-Urban Differences in Utilization of Diabetes Self-Management Education and Support in Arkansas, 2015 to 2019, by Rezahari et al. I hope I pronounced that properly. Previous studies have identified limited access to diabetes self-management education and support programs, or DSMES, in many U.S. communities. This retrospective cohort study examines rural-urban differences in DSMES utilization amongst individuals with newly diagnosed type 2 diabetes using the Arkansas All-Payer Claims Database from 2015 to 2019. The study looked at a cohort of over 42,000 individuals covered by commercial or Medicare Advantage insurance. A comprehensive statistical analysis was conducted, the details of which are available in the article. The authors reported that DSMES utilization was lower in rural areas compared to urban areas. However, after adjusting for county-level factors, including primary care shortages, median household income, and the population-based density of DSMES recognized programs, these differences were not statistically significant. For example, those in counties with higher density of DSMES programs had a higher odds of DSMES utilization. So the author's conclusions suggested that structural factors, including income and program availability, explain much of the rural-urban differences in DSMES utilization. Geographic context should be considered in efforts to improve access to diabetes education.
The next article that we found to be particularly intriguing was trends in nutrient intake among U.S. adults by diabetes status based on the NHANES survey from 2011 to 2020 by authors Liu, Pilla, O, Apple, Ye from Johns Hopkins. And the objective of this particular study was to see if using NHANES data, we could see a change in nutrient intake over time in people with and without diabetes. And so this was a traditional cross-sectional analysis of NHANES data, and there were all of the appropriate adjustments for age, sex, and race. And one of the intriguing findings, unfortunately, which is a same finding that we have had previously, was that individuals with diabetes and individuals either diagnosed or undiagnosed had higher average intakes of protein, fat, cholesterol, and sodium, and subtly but significantly lower intakes of sugar and potassium. But when you look at individuals who have diabetes, their carbohydrate, dietary fiber intake decrease. So maybe they're getting a message for decreasing carbohydrate, but at the expense of an increase in fat and saturated fat. And in people with diabetes, as we had seen previously in NHANES analysis, the healthy eating index was lower in people with prediabetes, diagnosed and undiagnosed diabetes. So if we're going to make a conclusion from this, we would like to think that we've been having information about high nutrition, and what they are finding is that nutrition intake did not improve in individuals with prediabetes and diabetes. And this is, I think, interesting in as much when you read it, we will think about strategies to augment our nutritional education in the US.
The next article I want to talk about is titled Barriers to the Adoption of Diabetes Technologies and the Implementation of Connected Insulin Pens in a Largely Minority Population with Type 1 Diabetes. And I find this particularly interesting as I recognize even in my own practice that probably we haven't used the pens as often as we could and gotten advantage of it. The author's objective was to assess barriers to diabetes technology adoption in a predominantly minority adult population with type 1 diabetes and to inform a quality improvement strategy to increase use. An anonymous survey was conducted of people with type 1 diabetes at the University of Miami Clinic. A Plan, Do, Study, Act framework was used to increase adoption of connected insulin pens among adults using multiple daily injections and who are already using continuous glucose monitoring or CGMs. The article itself has full details of their results, but some key findings were that compared with pump users, adults using injections with CGMs reported more overall barriers, including nervousness about reliance on technology, difficulty interpreting device information, and limited family support. However, a multi-component intervention in this population, who are already using CGMs, increased the use of connected insulin pens from 18% to 27%. The author's conclusions emphasized the importance of increasing adoption of diabetes technology in this population of minority adults with type 1 diabetes and demonstrated the efficacy of their intervention in accomplishing this goal.
Well, great, Rich. We have our next article, which is Barriers to Effective Type 2 Diabetes Care in Conflict-Affected Regions of Syria. This is a qualitative study of healthcare provider perspectives. So specifically, the objectives was to understand how healthcare providers sort of perceived their barriers to care. Methods that they used were semi-structured interviews, 15 physicians and pharmacists working in both public and private healthcare centers in Homs, Syria. These interviews were audio recorded and analyzed for thematic barriers. 4 of the major themes that were identified were unaffordable medications and unaffordable diagnostic testing, constraints because of medication supply instability, and workforce limitations that would limit care, and then restricted healthcare access, particularly for rural patients due to transportation barriers and transportation insecurity, and then gaps in the coordinated diabetes care because of workforce instability. So they conclude that in addition to the classic things that we see as barriers in the developed world of affordability, supply disruptions, workforce limitations, that you had instability layered on top of each of these, and that instability, the perception of these providers is that would sort of limit the ability for anybody to feel self-efficacy with their diabetes management. They also stressed in these interviews that they would like to see the incorporation of some basic psychosocial support into routine care that may really facilitate efficacy in resource-constrained environments.
Interesting report, Jane. And continuing on our theme of looking beyond the borders of the United States, the next paper I want to talk about is titled Enhancing Physician Clinical Competency a cluster randomized trial of a multimodal online educational program in a multidimensional diabetes workforce. And the lead author and really development of the methodology here is Nuhail Saeed. And as full disclosure, I was also one of the authors on this paper. It was a very interesting project. The global diabetes epidemic really does mandate that we have an effective diabetes management workforce available worldwide, and that's quite an undertaking. Scalable professional education is therefore needed to support that workforce, strengthening clinical competencies among these providers, including effective guideline implementation. So the objective of this study was as follows. It was conducted through the Ministry of Health in the Kingdom of Saudi Arabia, with its high prevalence of diabetes and really complex healthcare challenges. It assessed the impact of an online program that addressed physicians' diabetes care competency. Now, the comparator group consisted of physicians with access to conventional CME, providing standard diabetes medical care without structured intervention. The comprehensive needs assessment drove the design of the online educational content, which focused on diabetes management, prevention, and complications. The approach utilized current methods of continuing medical education, emphasizing critical thinking, clinical decision-making, case-based learning, and interactive activities. Details of the educational design and assessment methods can be found in the article itself. The conclusion of the evaluation of this online educational program was that it did significantly improve clinical competency among physicians in diabetes care. It underscored that a scalable and the key online, so it can reach all over the world, online educational strategy that utilizes modern approaches, modern educational approaches, such as interactive and reflective learning, can really be effective in addressing global healthcare challenges. And I'm very proud of this effort, and I think it's an important thing to think about as we try to impact diabetes throughout the world.
Well, then again, Rich, on I couldn't agree more, and we need a lot of insights on process of care. And so the final article that we want to highlight today is, and bring your attention to, is the Danish nationwide cohort of foot health in individuals with diabetes from the Danish Foot Status Database. Now, I chose this as one of the articles to highlight because this group, under Sorensen et al., have created a nationwide cohort description of individuals with diabetes attending a state-authorized podiatrist in Denmark. This is different than in a primary care clinic. And so this was initiated in September of 2015, and the data in the paper are analyzed through 2025, June of 2025. And they analyzed over 1 million unique entries from about 250,000 individuals with diabetes. And this was a pretty well distributed in terms of gender, and type 1 diabetes was about 6% of the group. But interesting to me, many of these people had had diabetes for only 2 years. And when they examined this cohort of people, so the average duration or median duration was 2 years, what they already observed was neuropathy as assessed by biothesimetry, aka tuning fork, was about 48%. About 12% had absent pedal pulse in the dorsalis pedis, and 19% in the arterial tibialis posterior. And 91%, I'm just going to stop there for a moment, 91% had some sort of malalignment in their foot. About 5% had a diabetic foot ulcer. But what this identifies is that if I have a cohort of people going to podiatry, I am already going to see advanced diabetic foot disease, which harkens us back to the early National Health Services report from the United Kingdom back in the 1980s, saying if you just tell people to take their socks off when they come into clinic with diabetes, and you can take a look at their feet, you can prevent the progression to this progressed diabetic neuropathy in these feet.
And I've seen people put signs in their offices, take off your shoes and socks. They're very important. So, Jane, thank you. We're nearing the end of this episode of our podcast, The Points of Care. We've talked about to the authors of two very interesting articles from this current edition of Diabetes, Obesity, and Cardiometabolic Care. And you and I have highlighted some of these other very interesting articles. Any thoughts that you might have on what we've talked about, Jane?
All I would say is I think that if this does not intrigue you to pick up the journal and look at it, I will be surprised. I think that there are many interesting topics here and of great import in day-to-day practice.
Yeah, the thing that I like about this journal is that it's a lot of good information, but it brings it down to the practical level for that people can actually use tomorrow morning, as I often say. Just a couple of other points as we come to the conclusion. Again, do want to remind our listeners about the two upcoming special podcasts to watch over the next month or so. One is The Cost of Obesity and Its Treatment, that's based on the inaugural journal symposium from Diabetes, Obesity, and Cardiometabolic Care. Another special podcast featuring the ADA podcast hosts, the podcast of podcast hosts, that will review the highlights of this year's ADA scientific sessions. So lots of exciting topics to listen to and learn about. So to our listeners, do be sure to see this edition of Diabetes, Obesity, and Cardiometabolic Care. Read the articles we discussed today, dig deeper into their design, methods, results, and the author's conclusions. And have a look at the many other excellent articles that you'll find therein. The full contents of Diabetes, Obesity, and Cardiometabolic Care can be found at diabetesjournals, one word, .org /DOCM care, CARE, with a link in the episode notes. Watch for our next journal issue and the next episode of this podcast, both of which will drop in mid-August 2026. And do subscribe to the Points of Care on your favorite podcast app so you won't miss what's next in diabetes, obesity, and cardiometabolic care. The Points of Care is made possible by our dedicated donors, listeners, and partners. Thanks to your support, we're changing the future of diabetes. I'm Dr. Richard Beaser. On behalf of my co-host, Dr. Jane Reusch, thank you very much for joining us.